Morning, everybody. Welcome to Pediatric Grand Rounds. Dr. Landon will be our speaker today. He's going to be speaking on concerning childhood asthma. And Dr. Landon is our Director of Pediatric Pulmonary, our Chief of Pediatrics, recently handed over running the Pediatric Diagnostic Center to Dr. Lee. And will be retiring from clinical medicine in probably 20, 25 years, something like that. Is that right? When he gets a new pediatric pulmonologist. But we welcome him. He's going to be talking to us about pediatric asthma once the slides start working.
Yes. Is there some secret to it? Somewhere else.
Vicky usually knows. Let Vicky run that for you.
Okay. I'm not sure what.
Is there a keyboard? I can do keyboard.
Yeah, we can do a keyboard too. There must be something going on with this.
Well, welcome to Ventura County's Pediatric Grand Rounds. As a long-standing pediatric pulmonologist here in Ventura County, I'm going to bring some of the experience that I've had. I also want to go over, of course, the basics of care, and then the kinds of things that are sent to me as consults, where I just wish people knew a little bit more. So we're going to talk about. Okay, those things. So now that we're ready to advance. So you will be receiving continuing medical education for this activity. So I wrote it as concerning asthma in children because it's not just about asthma care. I'm concerned about the continuation of asthma itself and the effect of society, of knowing that you can go to an event in Charlottesville and be run over by an automobile. That kind of thing is stressful. Having our President Trump and the way he handles our national affairs is stressful, and it does show up in your healthcare. And the upcoming perceived lack of healthcare is a problem. Our patients that we take care of are here from other countries, picking our strawberries, keeping us from having to pay $5 a strawberry. They are under extreme stress. So what we're going to do today is go over just the health experience in asthma as part of the talk, talk about chronic stress and its effect on asthma, and some interventions that can be done socially. Because what I see with our residents is we send them not just throughout the United States, but throughout the world, we have the opportunity to look at the social biology, the politics, the economics of each area. Tennessee is different from North Dakota. In Tennessee, they have 10 care. In North Dakota, they call it no care. So it is interesting to me that I have so few residents in my asthma clinic. It is the most common chronic disease in children. It's our leading cause of admission in the hospital, but it does vary by region and demographics. There are independent risk factors. We tend to think of it as just, oh, it's allergic asthma, it's infectious asthma, but stress, housing, economics pushes all these numbers over into increasing the amount of asthma in poor children. Severe symptoms, missed school days, emergency room visits, all can be affected by improving the social conditions that lead to the asthma. So generally you think of asthma, oh, well, it's all about medications and trigger avoidance and regular medical monitoring. But if you don't have access to regular monitoring, if you can't afford the medications, and if you're living in housing, and we shut down in 1 year 194 housing units, it took 2 years to bring them back on the market because of the amount of mold in the homes themselves. So we have to take a look. Not only were these people missing housing, but then they were also in inadequate housing as well. And then the cost barriers to medications. The medications now, if you are paying cash, for those of you who pay cash for an Advair at $400 a month and so forth, we need to have health insurance. We need to have a way to pay for these things to avoid the emergency room visits where everyone is forced to take their the patient in. And then school absences as well, because education is your way out of poverty. If you can't complete school, you're stressed for life in terms of your abilities to achieve. So we've got 1 out of 6 kids, age 1 to 17, has had asthma at some point. So I would like to see, again, more people in my clinic so we can do a better job as we send you out throughout the United States. Anywhere from 7 to 30% of kids are diagnosed with asthma at any one time. It doesn't result in hospitalization. We do have better medical interventions. And in Ventura County, what we see is the hospitalization rate is really the greatest for age 0 to 4. So a lot of infectious asthma rather than allergic asthma. This is California. So if you go to kidsdata.org, kidsdata.org, wherever you are in the United States, whatever region you're in, you can pull out your local statistics. So here in California, as you can see, we've got hospital discharges in terms of all the hospitals discharged. 7.8% are due to asthma. In California, 13.4% for mental diseases. So the burns is low, diabetes relatively low, endocrine metabolic, fractures is high in terms of hospital discharges. But really asthma at 7.8% in California is high. So when we take a look at just a map of California, we're sitting there in that 7.9 to 10.5% range. Now we've managed to drop over the years to now we're around 5.5%. And that's through our aggressive outpatient clinic system where we have access to medical care. We have people accessing social services and able to obtain the care that they need. And so over time, as you can see in California, the asthma hospital discharges have dropped, and here in Ventura County, we've dropped even more. What happened when I arrived here is we had a very high rate of asthma admissions, all occurring in a certain area, and it turns out the public housing in La Colonia was a very high rate of asthma admissions. If you, I went to the police department, went to public health, we made a map, and we were able to overlay violent crime with asthma, and they just lay one on top of another. So we went to the city of Oxnard and went about through their legal system, obtaining a gang injunction. And I was fortunate enough to participate in this. I was at Cesar Chavez Elementary School, and I was ticked off because the volleyball or the handball court next door was where all the heroin was dealt, basically in Oxnard. They'd hide behind that. And I go, cool, health and fitness, I need handball courts. But on the other hand, we can't have that. The entire row of housing in front of the school was all heroin dealers and drug dealers. So we brought in the FBI after they had someone shoot at me while I was at the school campus. So that ticked me off. So we put these melty Ford, whatever they were, Focuses on every corner with people in suits and crew cuts. So I was brought by the police department later on to a home because the gang injunction meant that you couldn't go out after 10. You had to get rid of your Dallas Cowboys gear and Dallas Cowboys license plate and shirt and hat and so forth. And there's the bedroom of this fellow had Dallas Cowboy sheets, Dallas Cowboy pillow, like he was a 5-year-old boy in love with the Dallas Cowboys. And underneath were AK-47s and sawed-off shotguns and so forth. So we did our best to bring down that atmosphere of violence, to improve the housing by intervening with mold and mite and so forth. But also we had regular asthma camps. And I asked a question that I said, gosh, how many of you feel like you can go outside to play? Nobody could. How many of you heard a gunshot? Every single hand in that camp raised their hand. Now, I don't know how many of you have heard a gunshot as part of your daily life, but it's stressful. So we're going to talk a little bit about the health disparities in asthma, talk about this chronic stress and how to intervene, but we'll talk about the medications as well. So when we take a look at asthma itself, there's what determines population health. And as you go throughout the world or throughout the United States, it's social, it's societal. We've got medical care, it's a piece, but health and the behaviors. And that's really what we're looking at now is trying with apps. We have a project upcoming with the Sierra Linda Elementary School where we're having the kids curate apps to pick out apps where it does help their health and fitness, something they can bring home to the parents, different ways of shopping. We're going to be tracking them with the monitors that can predict or can talk about how many calories they're actually using and so forth. And then genes and biology are in there as well. And the activation of stress occurs in utero. A woman who is pregnant in utero there's a different risk for their child after they're born for asthma as a result of the chemical soup of stress that these children have to swim through. So we tend to think of asthma as, okay, what starts your asthma? The picture up in the upper right-hand corner. We'll talk about that just for a little bit. So we think about the dust mite, so we can wash the pillows. We do our skin testing for looking at the allergic triggers of asthma. We're looking at dust mite, feathers, down pillow, down jacket, down comforter, looking at mold, cat, dog. And here, because we're in California, we tried burning down California a couple years in a row, and that didn't seem to wipe out my pollens for grass and trees and weeds sufficiently. So we have a season, January, February, March, of tree pollens, April, May, and June, grass pollens, a little break in July, and then August, September, October, November, we've got the weed pollens, and then inside come the cats, and the heaters go on, and the rain occasionally comes, and we get mold. And then we worry about cockroaches, leaving food out. So when we go to public housings, we really look at sealing up access for the cockroaches for food. If we can just do that in every single unit, and we've worked with our Head Start in terms of going home and making sure that occurs. We developed a BLA1 antigen for cockroaches, where you could just spray a little spray on, put on your woods light, and see where the cockroaches are. So we could do that. And this was with Harvard University. I went back to Roxbury, Massachusetts, and they go, "Oh, it's that guy from California. Oh, it's, hard bodies, soft minds, and you're not at Harvard." And I go, "Well, Harvard's at Stanford of the East. Come on." So anyway, they took me into this room with this 10-year-old boy and had me spray the spray on the bed, and then they put on the woods lamp. It was like an army of cockroaches had been crawling over his bed. The whole thing lit up. And what was happening, of course, was he had tennis shoes on, and he would jump on his bed, and so all the cockroaches that were from the carpet he managed to bring to his bedspread. So anyway, so we worry about dust, pollen, cats, smoke, roaches, pollution. We gave cameras to children, and had them film their house. Hey, I can't come to your house, and if I look through your windows at night and see what you're doing, then you call the police and have to wear an ankle bracelet and can't go around elementary schools. So what we saw was, oh yeah, cattail at the bottom of a mother smoking behind the wall, not wanting to have her picture taken, hairspray, the sisters with the hairspray. So we worry about smoke and fumes as well. Now, what we've done with our catch program is put spirometers in family care. All the clinics have them. And so I need spirometry, which is really the basis of how you diagnose asthma, to be done. It's good for monitoring asthma status, looking for evidence of asthma. Is there reversible bronchospasm? Does this flow improve by 12% pre and post bronchodilator? And then looking for evidence of other diagnoses, for restrictive lung disease, or thinking about congenital lung disease. And when we look at the maneuver, it's just blow, 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 keep blowing, keep blowing, keep blowing, keep blowing, don't stop, don't stop, don't stop, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, so that I can get the entire forced vital capacity out. And then I need the inspiratory portion as well, because a lot of what I see in consults are these kids who can't get their breath, and it's not responding. The bronchodilator, they gave me a spray and it doesn't work and everything's terrible. Well, what happens if you look at the bottom portion of the flow loop, if there's a block there, and as our ear, nose, and throat physicians know, if I could just scope them at the right time, they'll get a paradoxical motion of the vocal cords. So it's an inspiratory flow. It's not an expiratory flow problem. It's an inspiratory flow, and inspiratory flow is just not going to respond. And it has with good counseling, using 7-11 breathing, and then we also have them deliberately hyperventilate, because as you blow your carbon dioxide off, you feel like there's not enough air in the room, and we'll put an oximeter on. No, see, there's enough air. Your hands and lips will feel numb and tingly. You'll start to feel dizzy, and all you have to do is hold your breath for 20 seconds. This whole thing takes me about 3 minutes in the office to do. If it doesn't make sense, I have asthma out of control, not respond to a bronchodilator. Okay, let's do a pulmonary function test. Oftentimes just the irritation in the albuterol. I'll see the inspiratory curve affected. And these tools are available in your clinic as well. So that working on deliberately hyperventilating so they get that feeling, having their mother do it so they know what's happening with their daughter. And a lot of times the mom will go, oh, yes, this happens to me all the time. We have probably 6 ambulances a day with adults knowing they're having heart attacks who are having acute hyperventilation syndrome. So this happens in children as well. And the other thing where we want to make sure is that it does take practice. It's not something that you can do easily. So you really do need to have a calm, relaxed environment. Generally, we can do it in over age 4 with my cystic fibrosis patients. Certainly over age 6, they're pretty good at following directions, although, as you know, girls are smarter than boys and do it better. And they may not be able to perform, but it's that reversibility of the bronchospasm. So does it get better after the bronchodilator? Does their cough go away? Does their respiratory rate go away? And we want to make certain we're not treating something that's not asthma with medications that may not be indicated. We do grade them in terms of severity, but really anything less than 90% FEV1 is abnormal and indicates there's some form of lung disease going on, and we should see an improvement in someone with asthma after a bronchodilator. Now this is our stepwise approach. And so what happens with the patients who are referred to me, they're referred in on montelukast and albuterol. They have no aero chamber, and their asthma is not better, Dr. Landon, but it's chewable, and mom doesn't want steroids. Well, if we take a look at step 1, really, we talk about the rules of 2. Okay, how often do you use your inhaler where you need it? Twice a week. How many times are you up at night with a cough? Twice a month. How many prescriptions for inhalers do you go through in a year? Gosh, no more than 2. So when we have physicians who are working part-time and the mother calls in for another inhaler, it's not picked up. You know, on Monday they get it, and then Friday the doctor's back. And so as they exceed 2 inhalers in a year, that tells me that it's time for step 2. It'd be nice to have spirometry, but it tells me that we need to start adding in a low-dose inhaled corticosteroid. You see that montelukast singular is an alternative drug. It's not the primary. So really, they need an aero chamber, inhaled corticosteroids, because that's what works. Now, the kids for whom singular works, of course, I'm not seeing, but I do see behavioral side effects, and we'll talk about those. Montelukast is also a CNS drug and is associated with increased risk of suicide and depression. And so when I see kids under the age of 5 and the parents report sudden behavior changes, I'll take them off. You'll find me taking a lot of patients off montelukast. Step 3, we move up in terms of the inhaled corticosteroids. And step 4, we add in that long-acting beta agonist. Now, GSK had the SMART study, which was salmeterol was this medication I used to smuggle in from Italy. It's a long-acting beta agonist. And when they tried marketing it by itself as Ceravent in the United States, they got radio stations, and they had doctors who'd never seen the patients before and would never see them again, would prescribe it. And they were using it basically for advertising. 60,000 patients were going to sign up 60,000, and they stopped somewhere around 42,000. And the FDA said, well, you went to all that work, why don't you do some analysis? And as it turns out, your risk of dying was almost 4 times as much if you were on Ceravent alone. So they said, well, this is a bad drug. Well, it's bad if you're an inner city black male with heart disease who uses only emergency rooms for care. It doesn't have, as we've looked over time, doesn't have those effects. And we'll talk about that in just a second. Our step 5 now, high dose inhaled corticosteroids, adding in the long-acting beta agonist, and then finally our friends oral steroids where they're on and off, on and off. Now, as we head towards step 6, this is where Xolair or the benralizumab, the omralizumab, so these more expensive therapies. We have a patient who under stress, he is 17 years old, he'd been seen at Santa Paula Hospital, admitted in the ICU, discharged home. 5 days later, he's at St. John's Hospital, admitted to the ICU. They were concerned enough at St. John's, they sent a visiting nurse daily to see him. Well, his biologic father had appeared. He didn't know this fellow at all, and it appeared in his life. Now, when you start spending $60,000 to $120,000 in intensive care unit charges, then the $5,000 a month for these biologic medications starts to make sense to insurance companies. But short of step 6, the use of Xolair and the anti-IL-5, anti-IL-13 medications is really not indicated. So if we have someone who is in and out of the ICU, that's where we start to think. But in general, if I can get them decrease the stress in their life, get them compliant with medications, with an adequate medication delivery system, we can keep them out. Now, in terms of assessing control, so do they stay on inhaled corticosteroids the rest of their life? Well, no. We want to make certain first that we start out, okay, what is their level of asthma? Are their symptoms well controlled, not well controlled, poorly controlled? So are they having symptoms throughout the day? Now, you see, doctors close their offices at night. Have you ever wondered why that is? That's because your body's level of steroids is as lowest at 8 at night, and between midnight and 4, your body's level of adrenaline, epinephrine, is at its lowest. So fevers go up, coughs go up, asthma goes up. By the time you get that emergency appointment at 11 in the morning, your steroid level and your adrenaline level has peaked. And so the doctor will go, oh my gosh, I don't hear anything, everything's fine. So with the advantage of, again, not looking in their bedroom windows, I just have them take a quick movie of what their child is like. And what they're seeing, and they can now bring that into clinic so that we can get a better idea about control. But you can see where nighttime awakenings is just very important. Again, that's because of the endogenous biorhythm of our inhaled, of our corticosteroids and adrenaline. Activity limit, so 1 out of 4 United States Olympic athletes goes puff puff before they go out and break world's records. So there's whether they're faking their pulmonary function tests or not, exercise will definitely bring it out. As you chill the air tubes, it can certainly bring out asthma. And then how many beta-2 agonists are they using? So again, back to those rules of 2, as they start using more as your partners, it goes, gosh, your patient sure calls all the time for refills for their albuterol. And then exacerbations. So exacerbations are really where you get a step behind. You really get inflammation in the lower airways that takes 30 days to go away. It's not a matter of, well, he gave me an inhaler, I used it for 3 days, doctor, and now its symptoms are back a week later. Why isn't he better? Well, it takes a long time to recover down in the lower airways after an episode. So medication delivery devices. There was a story in Scientific American called Joey the Mechanical Boy. This is probably back in the 1950s or so. Joey, if he got more than 12 feet away from an electrical outlet, would power down. And if you pushed him within 12 feet of an electrical outlet, he'd power back up. Now, he was crazy. But that's what we do to our parents, is we make their children dependent on electricity when you use a nebulizer. So we are very aggressive in terms of utilizing the aero chamber with the mask. It comes in infant, pediatric, adult. It takes 8 breaths. I find a lot of people not instructing that. To empty that chamber out takes 8 breaths. Yes, you do need to clean it. So if there's a white powder around, there's electrostatic yanking off of the medication. And there's a little trap door in there. So if they're screaming, I don't care. Puff, puff, it'll stay aerosolized for a minute and a half. Oh, there's one. And then they grab it and go, God, I feel better, thank you. So we can move away from, I move people as quickly away from the nebulizer as I can, because the other thing that it does in my families is those who truly need the nebulizer are not going to the emergency room and are at risk of death because they're now giving their albuterol 4 hours, 3 hours, 2 hours, 1 hour. Oh, I don't want to go to the hospital. Meanwhile, it's driving down their level of potassium. The oxygen need is, there's an oxygen need that you can't see. If we put people in a room, if I put you out in the hall, you wouldn't, 100% of this room wouldn't see hypoxemia, wouldn't see cyanosis until somewhere around 68%. That's a steep part of the curve. It's not at 90 or 88 or 86 or 85. So somewhere in the 70s and 60s is where you actually see the cyanosis. So that's the other reason I hate nebulizers at home. I refuse to replace them, and really we want to push people towards these different devices. Now the other is the meter dose inhaler. If you just spray it in the mouth, great. Their mouth doesn't wheeze, so they need the chamber. Some of the insurance companies will only allow you to prescribe the Pulmicort. Well, if you give a dry powdered inhaler to a child expecting them to be able to inhale it, that doesn't work. So we have little duck call things. It takes about 140 liters per minute in flow. And so if they can't make the noise, they then they're not going to get the pulmocord in. You really need to use a meter dose inhaler like a beclomethasone or a budesonide or fluticasone. Okay, so I've touched on this already. The asthma deaths were not the long-acting beta agonists. They were elderly black men with underlying heart disease who were overutilizing an inhaler and accessing care only through the emergency room. So we've really moved away from this black box in terms of worrying about the long-acting beta agonists. Montelukast, again, boy, it was a great drug. Leukotriene inhibitor, we get that final cascade towards inflammation, and you don't have to change the dose. But these behavioral side effects that you'll see if you start asking your parents before and after, you really, again, are much better off with utilizing the aero chamber and the inhaled corticosteroids or the combination drugs. Okay, so let's talk about the asthma control test. So to me, I work for the patient. The patient's not my patient. It's my job to keep up to date and to educate them and help them to care for themselves. So what the asthma control test does is it gives them something that, and it's in your handout there and you can get it online. It breaks it into two parts. One part is for the child, and I use this really at all ages because I think it's important. The first part is the 24 hours. Hey, in the last 24 hours, hey, how's your asthma? So it's got little smiley faces. Oh, my asthma's good today, or my asthma's bad today. Hey, how is it with exercise? Oh, I don't like to play with sports, or I love sports. Everything's going great. How about at night? And how about cough? How's cough doing? So I need that for two reasons. I need that child to communicate with the parent. I'm coughing at night. I'm waking up at night. When I'm in school, I can't play. I'm not waking you up at night, but I am coughing at night. So we score these, and then there's something that both the men and women I think will understand. And what I tell all my parents: if a man is alone in the forest, is he still wrong? Of course we are. You guys haven't forgotten anything we've ever done in our entire lives. The process of inflammation in lower airways takes about 30 days to recover. So if we have an episode. I could probably ask any woman in the audience what was happening. Today's August 16th. So if I said July 16th, what happened? You go, oh, well, on Oprah, and I had my nails done, and this is what I bought, and my next door neighbor was diagnosed with breast cancer. You're able to remember where a man can't remember to take the garbage out or even where it goes. So the second part is over the last 30 days, how's your child's asthma been? Over the last 30 days, cough during the day. All over the last 30 days, how's that cough at night? And we score these things so that if in the 30 days, it's a matter of every single day, you get a score of 0. So as we add up the child's score, how they perceive their asthma, and sometimes you have to correct them, as with the MCHAT for autism, you just have to go over those questions sometimes. But as you teach them what it is you're looking for, if that score is less than 19, then they need to be continuing on a long-acting beta agonist, probably, certainly an inhaled corticosteroid, and 30 days later, when you come back in to help them, educate them, and control their asthma, if that score is now over 19, now you can step down. Now, by the time you get to me, it used to be, and what I see in a lot of practices that refer to me, it's step up. Oh, well, I tried this. Oh, I came back a month later. Yeah, I've been coughing for a month now. Okay, we'll try some Singular for a month. Oh, they come back a month. Oh, yeah, I'm still coughing. Now I'm depressed too. Okay, we'll try. Really jumping over the steps from step 1 to step 3 or step 4. So you're using more powerful medications and stepping down after a month, after they've had a month where they can exercise and sleep through the night. And then every child should have an asthma treatment plan. And in this asthma treatment plan, we used to hand out peak flow meters. They're going to be like testing for glucose and diabetes and just check your peak flow. And I had one grandmother write down every peak flow for a month, and she brought out an adding machine tape. So this thing went, and it green, yellow, red, she had it all marked out, and just ran it down the hall. I don't find that to be very useful in general. What really makes a difference is symptoms. And so cough is your first symptom. So in terms of the green zone, if you're able to run, play, sleep through the night, you're in the green zone. So that means you're not coughing. Now, one cough Oh my God, dig up Dr. Landon. Is that your asthma cough? Mom, I'm 65 years old. Can I leave the house yet? No, Dr. Landon says there's girls out there filled with germs. You can't kiss them. And so it's not just the one cough, but over a 5-minute period of time, if they're, hey, how are you doing? Yeah, I saw little Jennifer down by the slide. Oh, and she had a yellow nose, but she wanted to kiss me. So if I've got 1, 2, 3, 4 times over a 5-minute period of time, that gives me a score 2 and gets me into that high yellow zone. This is like driving down Mills Road, and the yellow light just changed. You don't want to hit that red and get a parking or get a ticket for going through the red light. So you want to get that medication going early. At that point, the medication should last 6 hours, 4 to 6 hours. If there's inflammation below, and all of a sudden you're going from 6 hours, 5 hours, 4 hours, 3 hours, 2 hours. When the kids are under the age of 2, oftentimes you will not hear audible wheezing. You won't hear a, you'll just hear that longer cough, particularly after dad tickles them or throws in the air at night. You're hearing that longer cough. So you may not hear a, so there may not be anything to fill in that next category of audible wheezing. As they deteriorate and are coughing more than 4 times a minute, maybe you're hearing a little bit of wheeze. The other thing we look for is when you have inflammation, when you drop the diaphragm down, decrease the pressure inside your chest, it's negative pressure. But if there's inflammation, then you can't get there, and then you'll start to see retractions in the ribs or abdominal breathing as it becomes more severe, and then respiratory rate. So we can add these things up, and what we want to do is keep someone hospitalized out of the hospital. So we want them to have oral corticosteroids at home. So I put garlic over my doors. I've never had a vampire come in my house, ever. It's a wonderful thing. And if you have that little bottle of oral corticosteroids, and as you hit this low yellow zone, knowing that you're heading towards the emergency room, then we give them a dose. It takes about 6 hours for the oral corticosteroids to kick in. So at that point, we're giving the albuterol every 2 hours, almost by the clock. And then by then, their cough has gone away, the retractions are better, the respiratory rate's down, and then we can back off. So if you start it at home, oftentimes it's just 1 day. So many of you get education in the emergency room where you go, I don't know if he's coming back. I'll give him 5 days and a tapering another 14 days. But if you start early, you can get away from that and start on the inhaled corticosteroids. We've tried inhaled corticosteroids alone, budesonide via nebulizer. It doesn't really work as well as just the plain old oral corticosteroids by mouth. And we want to do this in their language of choice, of course. So you want to do it in English. The portion up here is where I started, and that's the written instructions in Mixteco. So for the patients that we take care of, for whom there's no written language, it gets a lot tougher. And that's where bringing in either more frequent visits or a public health nurse to make certain that they have an understanding. There is the high, there's the Mixteco alta, Mixteco baja, so in the high versus the low. If you have someone translating who's from the high Mixteco to the low Mixteco, they hate each other. There's this higher has a higher caste. That's from 500 years ago. It's stuck around, and they will fight behind you. Go, I don't think I said all those things somehow. So you want to make certain that we're translating things appropriately and properly. Okay, so let's just go through some case studies. So here we have a 19-month-old nighttime cough, 3 asthma episodes in the last 6 months treated with oral corticosteroids, and usually this is infectious and intermittent. So what do you think? Well, it's mild, moderate, but it's pretty persistent actually. So we really want to be taking a look at this child in terms of that nighttime cough. Is he having symptoms during the day? Is his respiratory rate up? So he's someone who might, even at 19 months of age, need to be on an inhaled corticosteroid. And asthma education. So with daycare, if we take a look at the rate of infection, if you have 0 to 4 kids, you have your own kids, that's good for 4 to 6 colds a year. As you move for 4 to 6 kids, I take care of the neighbor's kids, I'm starting to make a little money at this is kind of nice. Moves to 8 to 12 colds a year. As you head into these septic tank daycares with children swimming around in diapers and mucus all day, now we're looking at 20 respiratory infections a year. That's 280 days of runny nose, 60 days of fever, and 30 weeks of coughing. So for my patients, by the time they get to me, one of my greatest interventions is get down to that 4 to 6 and less than 4 if you can. Try and teach people to wash their hands. Try and get a 2-year-old to do the vampire cough. We do our best, but asthma education and early intervention, having an asthma action plan, having enough education to go down on the medications, knowing what your medical home is so that you can be seen in one place. Okay, and his mom has asthma, he has milk allergy, so that tells me he's probably going to have immunoglobulin and in the future have a higher risk of asthma. Okay, there's my friend with the 3-year-old who comes in on montelukast, and he's waking up once a week with a cough. Is he controlled? No, not really. He's not well controlled. He's still coughing at night once a week. That's too much. So what should be done? Get back to the step plan. Montelukast, again, is not the place that I start at all. We'd switch him to an inhaled corticosteroid with an aero chamber, really look at adherence, and then comorbidities. Is he swimming around in diapers and mucus? And then education. And then following up in that period of time in which we see the decrease in inflammation, might be able to take him off medication. Okay, so now, oh my gosh, 6-year-old, we're able to get a pulmonary function test. The FEV1's 80%. Now 90 again is where we start to worry, and that certainly less than 80%, I'm very worried. So how severe is her asthma? Well, it's showing signs of inflammation, chronic inflammation, so it's moderate persistent. So with that, she needs to be on an inhaled corticosteroid, and maybe even the combined long-acting beta agonist. Now she has underlying heart disease. I would be concerned, but the main thing is checking technique, making sure they're adherent, so that we can get this out. But again, this is a child who needs a written asthma action plan, needs to be dispensed with self-management education, need to assess triggers. So this is the patient whom we're looking with skin testing to see if there's something else going on there, and really think about sending her my way. And then 2 to 6 weeks later, we may be able to go back down if she gets appropriate therapy. All right, here's your teenager finally, and they are using the albuterol 2 to 3 times every basketball game. So gosh, in an hour or 2 hours, they're sucking it down. We had a little girl at Santa Paula High School who we can estimate before she went down used her inhaler about 64 times. And that was just in her locker. She thought she could get high by sucking on her inhaler. And that, of course, was not good for her heart. Okay, so what would we do next? Well, check pre and post spirometry. So you'll see kids running up and down the stairs here. They all have low oximeters. So by the time they get to me, their parents are all excited. Oh, I've got a college education. She's going to get a sports scholarship. And they'll go, and she's running out of breath as she runs the mile. Well, you have to get into shape. Look at the Dallas Cowboys over there, and they're not just playing video games all year. They're getting into better aerobic conditioning. So what we do is a pulse test, and if their pulse after 5 minutes of exercise, where their heart rate is 140 or 160, we're following an oximeter. If it drops by 10, they're in terrible shape. If it drops by 30, they're weekend warriors. If it drops by 60, they're Olympics material. So if the aerobic conditioning makes a big difference, and it takes 3 months to get into aerobic conditioning. It takes 6 weeks to get out. So if you break your leg, you have a sprain, how come I can't swim to that raft out there that I used to swim to, and you drown halfway because you can't swim like you did last year. You haven't been in practice there. So doing it with spirometry is important. Performing exercise challenges is important. And then really thinking, gosh, maybe springtime, I have one little girl runs by Arroyo Verde Park when they're mowing the lawn and has an attack right there. Well, I wrote a note to her coach, don't run by Arroyo Verde Park while they're mowing the lawn, and she's done much better. So looking at the other possibilities as well. And again, back to the asthma specialist. And the combination therapy, even though it's only on their sports days, using a long-acting beta agonist, but usually a formoterol rather than a salmeterol. And even thinking about during springtime, if that's part of what's going on in that baseball field, using a combination therapy may be helpful. Okay, and then here's our 13-month-old infant. We've got winter coming up, so that'll be here soon as anything, November through March, or cough, cold, and flu season. Okay, he's got inspiratory and expiratory wheeze, respiratory rate is 60, O2 sat is 90% after an hour. So is this asthma? Well, probably. It might be RSV bronchiolitis all by itself, but it's this third episode. So what happens if you have a family history of atopy, of allergy, and you multiply that times RSV, the next 2 winters with every cold, generally they're going to wheeze. So that's where that asthma treatment plan is very important in starting the medication early. If they've been on an oral corticosteroids twice, you really should be thinking about an inhaled corticosteroid on a chronic basis, maybe even November through March. And then I take a lot of patients off in April. Okay, he's had his 2 treatments, got his oral corticosteroids. We want to think about other things that might be going on. Should he be in the hospital with O2 sat of 90%? Well, yeah. Now, what happens in the ER is you're giving them their albuterol. Oftentimes, their O2 sat will drop because that ventilation perfusion changes. Now you're ventilating areas, and the circulation has responded to the relative local hypoxia by constricting the blood vessel. So the air goes in before the circulation returns. And so as you give them the medication, you'll see their level drop. You go, shouldn't it be going up? Oh my God, they're getting worse. No, your treatment is effective. It's just you're stuck in that ventilation perfusion mismatch. Okay, so let's, in the waning minutes, I have quite a few slides to go through, so we'll go through these a little bit quickly. So if we look at the other parts, if we look at the societal stress, the question is toxic stress also taking our breath away? So this health model of stress, so as we take a look at socioeconomic conditions, as we look at adverse childhood events, what happens? Well, we've got socioeconomic, we've got living conditions, we've got social community conditions, we have just the individual factors, all that interacts and ends up in one of the diseases it ends up in is asthma. So we want to identify those risk factors. So as you're seeing the patient, it's not just prescribe another albuterol. What else is going on in their life in terms of the triggers of asthma? Now, when I said triggers of asthma, we try not to say that anymore because it is so violent. So we've tried to move over to causes of asthma. But as again, from my experience in La Colonia, triggers of asthma is a very real thing. Hearing a gun go off is just not good. So when we have a more comprehensive intervention, is that going to be effective? So they took a look with over 6,500 Latino and American children. There were recruitment centers. It was their asthma, did medical history, did the blood work, the exposure, the spirometry, the genotyping, the methylation. So is a DNA portion being covered or uncovered, and you're not able to read off that particular piece of DNA. Environmental, drug response, cotinine, that's the byproduct of nicotine that shows up in your urine. If you, oh yeah, my ex-husband always smokes around the children. Okay, but fine, get a urinary cotinine, and you'll see if they're exposed to smoke over your ex-husband's house. RNA sequencing, IgE, exhaled nitric oxide, which is a measure of inflammation, nutritional, social. So, they have any effect? Well, yeah, it appears right off that the minorities are affected disproportionately with asthma. So both Hispanic and this seems to have peaked. So way back when I started, 89, 90, 95, we did get much better medications and a little more access to healthcare, but our level of stress is certainly on the way up. So if we look at just the socioeconomic indicators and score 1 if your maternal low education, score 1 if your income is less than 25,000, score 1 if you're on government insurance versus 3 for private insurance, high income, high maternal education. Gosh, the asthma susceptibility as it starts going down as people are in better socioeconomic conditions, although this seems to vary a little bit African American versus our Mexican American. This is just looking again, so as the number to your moves to the right, as you have better income, better maternal education, the amount of asthma that's poorly controlled goes down. Now, the African Americans have a unique set of genes in some where they can become very resistant to the beta-2 agonists. As you use them over and over again, they become resistant. And so we have just an innate problem with more asthma. But as you can see, again, as all these factors move up, we have more people controlled and at least partially controlled, and our poorly controlled really decreases in terms of percentage. And plus, just the stress. My daughter is a child of color, and she was raised in Ojai, California, where she was probably the only child of color in Ojai while she was in elementary school, and she felt it. She felt it at school. She felt it in the doctor's office. She felt it in stores and restaurants, streets, public settings. Someone she was, they were doing PE and jogging, and they were chased by the skinheads from Matilha Junior High School. So there's a stress that goes on, a societal stress that is different and adds in. So in terms of these experiences of discrimination, the problems with being poorly controlled for asthma also go up. So again, this is a cycle. So if we're going to intervene, we need to identify where we can intervene, and there are cumulative effects over time. So adrenaline itself is a nasty little hormone to have. I mean, it's very advantageous. I mean, if you're at Jurassic Park and dinosaurs are coming after you, it dilates up your eyes. You can see the velociraptors coming at you now, makes your heart beat stronger and faster, decreases the blood supply to your stomach, so you can move that muscle and those energy to your big muscles, makes your brain work faster, dilates up your bronchial tubes. But in terms of stress, it also causes other effects. So that being under constant stress, what it's happening to your brain when you're very sensitive to the heart rate, when you're starting to breathe faster because you're under stress, because you're going to be making more carbonic acid because of the running and the tricarboxylic acid cycle. Well, if the only stress is upcoming homework, one boyfriend found out about the other, it's different from being attacked by Tyrannosaurus rex. And unfortunately, as you can see, there is a physiologic response down to the glucose, C-reactive protein, IL-3, IL-4, IL-5. These are all having to do with asthma, the IL-13. So that we also see effects right down into the prenatal period. So this is kind of generally what we'll see with asthma. Again, those early transient wheezers, and then we have these kind of non-atopic wheezers who are starting to kiss girls in pre-kindergarten, and then that really just falls away. So you can look at the parents in the eye and say, yes, you're going to have a bad 2 years. Your child is under the age of 3, but it's going to go away. If they start with their asthma a little later in life, it's going to go away. It's going to take some time, but by age 10, 11, puberty, maybe the only advantage to puberty is for those kids. For the parents, puberty is still miserable, but the IgE-associated asthma, again, tends to increase. So these pro-inflammatory responses, we're looking at adverse childhood events, also increases asthma. Your odds of asthma as an adult, if you've had a bad childhood, whatever the line is from West Side Story there, I had a miserable childhood, Officer Krupke. But it does make a difference. So that with time, as that the screen for adverse child, did your parents yell at you? Did you have money problems as a child? There's 20 questions to go into this index. It's a problem, and it affects your physical health. And this is looking at prenatal and postnatal stress. You can see low prenatal, low postnatal, high prenatal, low postnatal, low prenatal, high postnatal, high prenatal. Well, there's within those levels of confidence, we see that the effect of stress, even in utero, increases your likelihood of having problems with asthma. There's also the beta-2 receptor. There's a difference there in terms of healthy versus asthma, but also just the chronic stress as you're exposing yourself to that endogenous beta-2. Problems in terms of even your microbiome, which is under study. So, I'm stressed, my genome is being methylated, I'm anxious, now my genes are being methylated. All these things do occur with the occurrence of those stress hormones. So even down to your DNA, it's not just a matter of your brain, it's happening down at the level of the DNA, even right down to the receptor genes themselves. So just to come into summary since we're running towards the end of our hour. It's complex. So there's asthma, there's medication treatment, there's control, there's having an asthma action plan, there's stepwise planning that we want to do. But if you're going to make an impact as you leave the residency, if you're going to make an impact in your local community, we really need to have a multi-pronged approach, something that's comprehensive in nature. And I'm going to stop there. So, go forth, treat asthma, but don't forget the social stressors as you enter your community and be aware. Are there any questions? Since we're at the end of our hour.
What causes the cough? Is it inflammatory, or is it hefty fever, or reflux, or what?
Yeah, so when you put out leukotrienes and cause local inflammation, then you will get a feedback loop. The feeling that your chest is unable to come back to normal, or you feel hyperexpanded, that's physiological, that's swelling. And so when you take a breath in, it's unable to escape. It's like blowing up a balloon. So you open up the airway as you drop your diaphragm, decrease the pressure, but it closes early because of the inflammation there. So you get some of that cough as that inflammation, both from the chemical side, but also the air trapping side. Dr. Harney.
Thank you so much, because this makes me feel a lot better about myself in my ability to treat people, and for the fact that I'm not just treating them poorly and I'm missing a bunch of things that I can influence. But so here's the typical, and you know this way better than I do, but here's the typical winter for me half of the time, is you have a 3-year-old who has all of these risk factors, living in a condition that's not, beneficial, having a single parent who's under multiple stresses, being in a daycare where there's more than 6 or 10 kids, and they have a family history of asthma. Now, they're not at the point where you're really putting them on steroids all the time, but you're seeing them for the 9th time within 3 months, and the parents are begging you that something's wrong with your child and you need to change it. What, we go over these things and we try and influence the things that we can, but is there anything that you found in your wealth of experience that can help to, just alleviate those things?
Well, you're right. So November through March, I think Symbicort stock goes way up, because what makes a difference for those kids, and what you've described is an asthma control test that's probably somewhere around 9. So they're having more than, in the 30 days, 15 of them, they're coughing. 15 of them, they're coughing during the day, they're coughing at night. The child at age 3 is unhappy about not being able to run away from the girls because he's so cute. He's coughing during the day. So for that, you're somewhere around step 4 or 5, and then you would add in a long-acting beta agonist, inhaled corticosteroid, check them back a month later. If it had dropped down to the score had improved greater than 19, then you drop them down to inhaled corticosteroid alone. But I have kids who November through March are on Symbicort or another combination, and that, depending on what the insurance covers, Dulera is another one. And we've really freed up. I mean, when you look at albuterol, in terms of the FDA, is it approved for the use under age 2? No. So if you feel more comfortable with me prescribing the long-acting beta agonist for someone who's 19 months old, that's what we'll do. I mean, we used when formoterol was cheap, we used formoterol plus budesonide and open up the powder and so forth. Now Performist is out there, but Performist is, I think, $1,000 a month because they can. But that long-acting beta agonist, inhaled corticosteroid, and really looking at changing that asthma control test and something that's acceptable for people. Stopping smoking, I have one little 5-year-old who came in. I opened the door and the door blew off. I go, what the heck's going on? Mom and Dad's sitting there. He's not home that often, I guess, because she was wearing so much perfume that it was like being in a forest fire. I asked her to leave just for a second because I couldn't walk in. And finally we aired her off enough where I could sit there and take it. And what he had 3 teenage sisters, God help Dad, no wonder he works all the time. And what they would do is they would hairspray themselves every day, spray perfume all over themselves every day, and they would spray cologne all over him because he was so cute. And they wondered why his asthma wasn't in control. So, you know, fumes can be part of it. The HEPA air purifier is about $130. If I've got a bedroom where they're waking up with symptoms, we've washed the pillow, covered the mattress in box springs and plastic, then HEPA air purifier. Cats are ubiquitous antigen. We looked at bus benches here in Oxnard, found cat dander on every single bus bench. And it's not the cats are shaking the paper, sipping their Starbucks, waiting for the bus to come. It's everybody brings their butts with them and their cat dander. It's very sticky. And it comes from licking. It's not, you can varnish a cat, I guess, but if you can wash a cat, you will wash off that protein. It's just you have to call the emergency room first. I talked to Dr. Ehrlich. I said we're going to try and wash a cat, get all the suture in the hospital because we're going to try and wash a cat. So you can take them to the vet. They'll wash them. You can throw them in a glass shower and turn it on, and they do all kinds of funny things. I had an email how to wash a cat. What you do is you go into the wash receptacle. You place the cat. Half a cup of detergent in, place the cat in the wash receptacle, put down the lid in the seat, go through the wash cycle, then go through a rinse cycle, and pull up the lid in the seat, let them run outside and dry off. That was sent to me by someone named the Dog. I don't know if you've heard of this guy. So the dogs, it's their poop, it's their pee, and so unless you're blocking up everything, this hypoallergenic dog stuff, it's not just their dander. So. I like animals outside. I think cats are evil, alien, from another planet, Egypt. I don't know, but yeah, some people seem to like them. They like the videos, I know. Sorry. I'll take my medication. All right. Well, thank you so much. There's more in the handout. I didn't want to go through the last 20 slides. Okay. Did you watch it on your phone?